Thanks everybody for taking the time to join us on a little, we thought it would be helpful to give a briefing on what at least direct relief lens is in the unfolding situation in Ukraine, and hope to give you kind of an overview of things you might not hear from other sources. Sensitive to that, there's so much news coming out. I'm Thomas Tighe, I'm the president and CEO of Direct Relief, and I'll be joined in some of these briefing remarks by Dr. Andrew SCHROEDER, who leads our research and analysis efforts. So he'll give you some of the an overview of some of the things he's been doing with some of the international agencies and tech firms that gives you a lens on people movement and some other issues. And then Dr. ALYCIA CLARK, who's director of our pharmacy and clinical affairs, who's been pretty deep into the weeds of trying to look at what we can do at Direct Relief to complement and support the efforts both within Ukraine and in the surrounding areas. So I think just to start off, Direct Relief there's a lot of lanes that are on the same basic highway of humanitarian support. There's food, water, shelter, resettlement, jobs training, psychosocial issues, many of those things directly, none of those things directly really does. I think in the area that we're focused on, it is really providing medical material support, including prescription drugs, vaccines, and cold chain medications to assist in general the chronic gaps that exist, as well as when emergencies happen, get much bigger. So for the past 7 years, Direct Relief has had an ongoing, relatively modest support effort in Ukraine, where we can help fill gaps that aren't being covered by either the commercial marketplace or government programs that exist, and that role that nonprofit charitable organizations play that is not competitive with either governments or markets, but really filling a gap. In the last 7 months, that changed a bit because Direct Relief was asked by the ministry to assist with some primarily COVID-related activities several months ago, where we were in the position to provide the monoclonal antibody COVID treatment that Lilly was gracious enough to make available for humanitarian use, and Ukraine wanted. So that became an effort that led us, as is the case with everything, when it's prescription medication, every country regulates and it's a highly regulated industry. So regardless of what the circumstances are, it's really important to do it well through the appropriate channels. And Direct Relief is an accredited drug wholesaler here in the US in each of the 50 states and US territories. So this is kind of what we're kind of specially suited to do. I think 2 weeks ago, a few days before the invasion happened, the most recent delivery was kind of typical for Ukraine, which was cardiovascular specialized medications and some cancer therapies that had been requested by the ministry, approved and cleared. And that flew into Kyiv and was accepted very graciously, and it all worked fine. Then the invasion happened. So I think that, obviously, fundamentally, the circumstances have changed. It went from peacetime to wartime, from normal commerce to completely interrupted supply chains, normal functioning economy to in society, to millions of people fleeing in crisis, being targeted, killed at increasing threat each day. And what Direct Relief has been doing the last 2 weeks almost now has been basically riding on the same backbone that existed. We had a good channel and connections to the Ministry of Health, and the NGO that we've been working with, relatively small, in Cherkasy, which is about 100 miles southeast of Kyiv, that has just been a great local partner organization. So as always, I think the context for any emergency is that's disruptive and causes people to move, whether it's a hurricane or flood or fire or earthquake, is the mass movement of people in and of itself creates certain health risks. There's a lot of chronic disease in the world, and those with diabetes or asthma or hypertension can function normally and keep their condition under control if it's well managed. When it becomes unmanaged, when people have to flee, it can become an acute health crisis in relatively short order. So among the things Direct Relief does on an ongoing basis, and the lens we bring to Ukraine are things like the support for patients with type 1 diabetes, which is a program that we conduct the backbone support for and physically handle the insulin to about 40 countries to help children and young adults with type 1 diabetes with donated charitable insulin, which we do a lot of. Again, that happens to be a Lilly supported program, but we also receive insulin from Novo Nordisk and the other manufacturers. And so, but that acute sensitivity to it's about 13,000 children and young adults in Ukraine who have type 1 diabetes. We work with the International Diabetes Federation, the Ukrainian Diabetes Federation. So in the scope of what's happening, that may seem like a rather narrow issue, but it's something that direct relief can do. So we're focusing on that. Earlier this morning, we had a call with the head of the World Health Organization's non-communicable disease section, Dr. Slim Lamas, and we were working through the same issues. They also are working to support the Ukrainian Ministry of Health as we are directly. They're concerned about diabetes as well as other non-communicable diseases. And so we were kind of swapping notes and trying to make sure that, in the absence of precise information about specific, facilities treating specific numbers of patients, you're unavoidably forced to make estimates based on the best information you have. So I think for the children and young adults with type 1, the number of people in society with type 2 and are insulin dependent, those are things that we've spent a couple hours on this morning, are doing our best to mobilize, not only kind of sizing the problem and the horizon that we're looking at, probably at least 3 months to begin with, but then the logistics of making sure that the product integrity is maintained. We have Direct Relief has a facility, a licensed distribution facility in the Netherlands where we have significant stocks. We stage material from there for international support, but it's great to have that capacity in the EU in a controlled environment. And we're reluctant to take anything out of a controlled, accredited drug supply chain and put it into a general depot. You cannot treat medications like you treat food and clothing and water, where it's okay to have a resettlement center. People can figure out what to do with that. So I think the complexity of developing kind of on the fly and taking advantage of the situation being in Europe, what is a channel that gets materials that can be staged and can fill orders and make the allocation without losing the integrity that's important to maintain for the drug supply. So, in general, we're looking at what things we always look at: the chronic becoming acute, the compromised distribution channels, which often happens in natural disasters, when you have a spike in demand and you have a contraction in the ability to supply because the distribution channels get either clogged or broken. The main difference here, you have a spike in demand and a contraction of the supply channels, is that in natural disasters, literally everyone is trying to open them up. And in this case, you have the Russian military trying to restrict them further as they bring Kyiv and some of the other cities under siege. So I think the workaround for logistics has been a challenge. It's very fluid, but it's something that so far has worked. The Ministry of Health of Ukraine has a good system that is functioning, and the direct release workaround has been working so far for the first two deliveries that have been sent and received, and the third one leaving today, that basically routes through Poland, goes in bonded truck to the border, and it is taken custody of by the Ministry of Health officials for use wherever they want. So the first few, I think it's the crisis acute trauma care really supplanted last week the concerns about just general drug availability to keep people safe and healthy. That was reversed and said, just send the trauma. We have these packs that are like the ones behind me, developed for that purpose, initially for the Medical Reserve Corps members in the United States. So there's basically an advanced medic pack for field use, and that is what the ministry wanted. Those were flown over. We've flown over some since, and they were received, as I mentioned, through Poland, transported in bonded truck to the border, and they have been, we got confirmation they are being used and have been used in both Kyiv and Kharkiv in the past week. So I think the channel remains open, but that's subject to change. The health needs are obviously spiking. We're doing all we can. We have some generous offers of transport for a charter or large scale, which we often do. And there's substantial inventories that have been made available by the healthcare companies that Direct Relief often works with. That response has been tremendous and supportive. So I think the supply availability is going to be not the short-term problem. The short-term problem is going to be good information and a logistics channel to connect that available supply to the current demand in a situation with incomplete information that changes a lot. But so far, I think that the distribution channel into Ukraine is functioning, if tight. The circumstances obviously are shifting. And in the background is the movement of a few million people that Andrew will talk a little bit about, which some is known, but not all. And so again, the more specific, the better the response. But I think, starting to home in on what the demographics and health needs look like. A lot of the focus obviously in Poland, but people fleeing to all the bordering countries, with perhaps Moldova receiving the largest per capita, about 10% of their resident population has arrived in a period of a week. So, we know from experience that the disruptive nature that has to the equilibrium of a society, but kind of extraordinary how many people are not in camps that we're accustomed to seeing in refugee situations, mainly in Poland, how many people have been accepted and welcomed into people's homes. I could probably bore you with all sorts of random detail, but I do want to just turn it over. Just wanted people to say thank you for those of you who are interested and have been part of this effort. We have been asked by multiple parties to withhold some of the information regarding logistics that we can't get into just because of the operational security that has been present. So I can't talk about kind of the specific routing, border crossings, and how that's working, just that so far it is. And we have, fortunately, good ties to senior officials in the Ministry of Health and in a channel that has been functioning well so far. And we're working with WHO, I think, comparing notes. I think we'll be able to work with them in the near term on some of these tough logistics issues related to insulin availability for people who need it in Ukraine and perhaps in the surrounding areas, but it's unfolding fast. And as we get to, we'll talk for a few minutes each and then loop back around. If there are questions, you can send them in and we'll try to do our best to answer them. But for now, let me turn it over to Dr. Andrew Schroeder, who's our directly head of research analysis, and will enlighten us all. Thanks, Andrew.
Thanks so much, Thomas. I wanted to just kind of quickly start with building on what Thomas was saying about some high-level observations about the health situation in Ukraine, and then spend most of the time looking at the refugee crisis in terms of work that we've done to look at refugee flows by analyzing mobility data, social media collected data that illustrates where some flows of population are going, and then some work to understand some of the needs of the refugee populations as they continue to diffuse throughout Europe. I think as Thomas mentioned, the key kind of issues within Ukraine at the moment really can be bucketed into a few areas. The principal one is obviously around physical trauma and combat injuries. The official numbers now are at 1,500 or so casualties, about 450 killed. Within that, that's considered an undercount. So that's also led to a displacement of individuals who, were being treated for other serious illnesses in the hospital systems as they exist still. So there's a triaging effect going on. Prior to the war, obviously, the leading cause of premature death in Ukraine was cardiovascular disease, and then cancer, diabetes, and mental health and other mental psychosocial disorders. So that really hasn't changed. In fact, actually, the mental health and psychosocial disorders is probably receiving some of the least attention recently, but really ought to be elevated, especially as it relates to refugees as they spread throughout Europe. We've seen that the disproportionate share of folks that are fleeing the war are children and their caregivers, often their mothers, and other extended relatives, people that have mobility impairments that often were most at risk for chronic illnesses, hypertension, cancers, other things, may actually not really be able to travel long distances, may be adversely affected in disproportionate ways. And so that's worth bearing in mind, as well as disability issues, which come up for direct relief in every natural disaster that we face. And in this particular war, that's also a kind of key issue around the ability to provide for the needs of those that may be disabled prior to the war and have disproportionate kind of disease risk, but may also have a harder time moving. Infectious disease transmission is a significant issue. There was a polio outbreak in Ukraine just prior to the outbreak of this war. The polio vaccination campaign had to be suspended as a result of the outbreak of conflict, and that leads to an ongoing risk of polio transmission throughout the country. So things like this indicate, not only the specific risk of polio, but kind of the broader context for weakness in the vaccination system within Ukraine. And in that context, it's important to remember that this particular conflict started on February 24th, but really has been ongoing for many years. The most recent outbreak back in 2014, led to the largest measles outbreak within Europe. There's a significant risk of those kinds of things happening again. So as we think about, a lot of these kind of mobility dynamics and the relationship to the pre-existing health system and how that's been impacted by the conflict, I think all of those become even greater concerns. Just one other kind of thing that is worth really bearing in mind is that the areas of Ukraine that have been most directly affected by the fighting also are home to a number of hazardous facilities. And one of the kind of key dimensions being tracked right now is actually the impact on human health from those hazardous facilities. The most famous are the nuclear facilities, but there's a range of others around Ukraine. The most recent count is that 30 attacks have been registered so far on hazardous facilities, chemical storage, nuclear facilities, other kinds of industrial storage that have, if material is released, have a significant negative impact on the surrounding community. That is likely to grow in scale as the fighting intensifies. So when we think about the refugee crisis in particular, and as according to UNHCR, the current count on refugees that have fled this conflict is over 2 million. The upper bound is estimated at 5 million potentially. This has happened in the course of about 10 days worth of fighting. This is the fastest spread of refugees from a conflict, particularly in Europe, ever recorded, and continues to flow day by day. So as Thomas mentioned, this has been principally received around the neighboring countries. Poland has received the largest number overall, over 1 million. I think they're at 1.2 million right now. Moldova, which is the, in terms of their kind of underlying social systems, the health system, et cetera, is probably the weakest of the group that includes Romania, Slovakia, Hungary, and Poland. And Moldova, for instance, has a 25% COVID vaccination rate, which is the lowest of all the neighboring countries. They've had also significant problems that are echo the problems of the pre-existing health system within Ukraine, problems with chronic disease, with limitations on access to healthcare, et cetera. So as you see increasing concentrations of people, what you're looking at is the map of the Polish-Ukrainian border, measured in terms of the probability that you've seen statistically significant change in that specific area of the incoming population since the 24th of February. This is recorded as of the 5th of March. And one of the things to point out about this is the rate at which diffusion away from the border has happened. So this is looking at an area that extends a couple of districts into Poland. The cities that are recording change range far and wide around this area. As we have an effort to take the people that are flowing through those border checkpoints, which you can see with those sort of yellow markers on the border with Ukraine, and move them into and around the country as a whole. So that has now indicated that Poland has seen extension of refugees throughout virtually the entire country at this point, with the greatest concentrations happening in Warsaw, in Krakow, in sort of bordering regions in western and southern Poland. So not really concentrated anymore in one place. And one of the things that we're sort of paying special attention to as we kind of think about what's likely to happen over the longer haul is the diffusion into areas where you have connections between Ukrainians and other communities in Europe. So the darker green areas in that underlying base map are looking at what's called the social connectedness index, which is a measure that's derived from the Facebook platform, which looks at the likelihood that someone, in this case from Ukraine, has a high number of connections to people that live in one or another areas of the surrounding countries. And what we see in almost every case in other refugee crises is that, conditional on just the physical ability to get where they're going, people tend to congregate in areas, or they tend to prefer to congregate in areas where they actually have some underlying connection to the local population, where they have friends, family, or other community members that can connect them with resources, jobs, other kinds of care. And so as we kind of look at this diffusion pattern over time, with this particular one looking at the movement from a couple of days ago, we can expect that we will see concentrations in areas where people have social ties, of course, mitigated by just the profound shortages that are being seen around access to housing. I talked with Airbnb not too long ago. They made a commitment around opening up 100,000 Airbnb units. Even this is a significant strain to be able to find significant housing stock to be able to provide for the incoming flow of people into these areas. So monitoring how that kind of happens, and what then the pressures will be around the kind of absorption of that population, their health needs. We've done some kind of initial polling, looking at crowdsourced information on the reception of refugees and what their needs are. And I would say that the number one kind of perceived health need is actually around mental health and psychosocial support. The people that are coming through have been traumatized. They are in extreme distress. They have a lot of open questions about how they are going to rebuild their lives as they go forward. And this echoes people in any number of other disaster situations where we've seen that mental health support becomes actually quite significant. And in this case, the suddenness of the shock and the violence of the conflict add to that kind of effect. So prioritizing that as people are absorbed into other areas of Europe seems to be something that we can really identify and prioritize. And these just the mapping products the analysis that we're doing around the flow has been shared out with colleagues at the World Bank, at Médecins Sans Frontières, through the health cluster, through UNICEF, through UNHCR, and a number of other agencies. So we've been doing our best to kind of play a productive role in informing the broader understanding of how these dynamics are playing out, where clustering will occur, and what kind of needs that's likely to provoke in the population. As we see this become an all Europe phenomenon. In the reporting this morning, the Czech Republic reports now 100,000 refugees from Ukraine arriving in their country, and this will continue to spread throughout the continent. So I think that's where we're kind of at right now in terms of our understanding of where this is going.
Yeah, Andrew, if I can hop in, because a couple of questions came in, and I think maybe you can respond to them. And just I think someone had asked about the as people are getting to Airbnb and not being in camps, it may present some challenges. How do you make sure they don't disappear? Again, as I mentioned, we're kind of rather narrowly focused on the health and medical, but it relates to that too. I mean, if they're just getting into an environment, has there been any discussions? I think Andrew's kind of working with the analytics teams at a number of different universities and that sort of thing. But has that come up at all?
Yeah, I think that's a really good question. As a policy-wise, part of that's a policy question, part of it's a monitoring question. I mean, so far, the rate of refugee flow has been enabled by a relatively free kind of movement through the border. So it's not logistically easy to let 2 million people through the borders in 10 days. So there hasn't been a ton of sort of strict requirements placed on where people are supposed to go when they get there. So the policy structure around that is still evolving. There's a set of recommendations that are made through the governments around kind of check-ins basically with local kind of authorities as people are kind of offered rides and offered services in a pretty wide array of areas. I don't really know that there is a plan for sort of tracking and monitoring all 2 million plus people that are coming through. I think it's not necessarily feasible to do so. In terms of for instance, healthcare access, I mean, for folks that have a sort of biometrically identified Ukrainian passport, as of right now, they're supposed to have access to the European Union health systems so that they can receive at least basic care through the European Union health systems. And then that would then be registered within all of the systems for tracking where people are kind of using services. There's, service delivery. I mentioned Airbnb, they can obviously monitor uptake of those services by people that are coming through. I talked to telecom companies that can, people have given free SIM cards. It's possible to understand the distribution of at a highly aggregated level of where people that have had, that have come in, using SIM cards, that how they diffuse out. I don't think that's an individual monitoring solution. That's like a aggregate flow solution to understand where you ended up. Obviously, there's census taken at the border when people come in, so they know about kind of the high level movement, how many people are in any given country, et cetera. But it's a problem. I mean, anyone in the world would have a problem tracking that number of people coming in such a short period of time. So.
And I think just for context, I think, Andrew spends a lot of time working on kind of the vulnerability index. And so in general, not everyone's equally vulnerable in life, and the three principal factors, and I can give you the layman's view, but it's like the built environment, the natural environment, and demographics. So if your demographics being who's vulnerable, very young and very old, people who have a pre-existing mobility issue or a disability of any type, it's sort of obvious, or people who are living in an area prone to flooding, or people in the built environment subject to pollution or whatever, if they're near a nuclear power plant or coal spewing plant. So I think that's a framework that helps us kind of generally understand. But in this case, with 50% of the people being children, I mean, there's vulnerability of being a kid, maybe less so for COVID, at least getting sick from it, but from other things too. So I think all that gets into the mix. And again, as I said, if you don't have the specific information that, best case is you're filling a specific order, that's not possible. So you have to use these existing frameworks to understand it. But I think what you said, Andrew, there was another question that came in about something that we're aware of, and maybe you have a better insight than I do, but you mentioned the Ukrainian biometrically identifiable passport holders, but I think there have been reports of African students and other folks in Ukraine not being treated similarly. And what's the status of that? And, it's certainly, as I mentioned, just directly, so far it's been focused on within Ukraine. How can we, continue to flow resources in there while the channel's open, and we can do that. But certainly that's a big issue, and something that we would be concerned about and are involved with in other places.
Yeah, I mean, I think it's a really important point, actually, and I don't know about the kind of current numbers as to how many people this applies to. I mean, it's really important to remember that Kyiv, in particular, was a cosmopolitan, large-scale city with a large number of international students and others that were in the city when all of this transpired. There's been quite a few reports that have been reported throughout the news of unequal treatment at the border as people have been allowed in. There were 4,000 Nigerians, a number of people from South Africa, Ghana, etc. Each individual country that represents those groups has had their own embassies that are advocating for what happens to those people when they are, to deal with any kind of problems, deconfliction at the border to make sure they're able to get through. The African Union, for instance, issued a statement calling for equitable treatment at the border and making sure that that is handled in terms of immigration policy, et cetera. So that's kind of one issue. I think the other question comes up is, like, do those folks have access to services once they get into the European Union? Are they actually resettling? In many cases, they may not actually resettle within the European Union. A lot of these folks were, say, international students, as I mentioned, or similar folks that were in Ukraine for other reasons, and may actually return to their home countries. I think the government of India is repatriating thousands of people from who are Indian citizens who have now been able to leave, but are not actually being resettled within the European Union. So I think trying to figure out, like, the numbers on that, how many people actually are in this situation where they would have potential for inequitable treatment inside Europe, and then how many people are actually going to be, moved from now that they've been able to get through the border and they're still coming through, can they go back to their home countries? Do they have to go somewhere else? There's a whole set of different kind of accommodations that their own countries are often in the process of negotiating. So it's clearly an important, point just to remember broadly that, we're not very far removed from the Syrian refugee influx, which saw a very different response for refugees coming into Europe, and the fault lines that existed then around debates over outsiders coming into home countries and the kind of political turmoil that attended that. I don't really think there's any reason to believe that that has gone away in any measure. Obviously, this situation feels different for folks in Europe, given the proximity, given some of the cultural ties, et cetera. But, there's an important sense that this could go on for many years. I mean, Syria started in 2011. It's still ongoing today. We've seen that refugee crises don't tend to diminish quickly, arguably, if ever. So planning for the long-term impact and then trying to forecast out where you're going to actually be able to absorb people the best. I mean, to me, this is one of the reasons to focus in on questions around social connectedness, is that, one of the advantages is there is actually a number of fairly strong communities that do have deep ties to Ukrainians, and there will be a lot of leaning on those areas to, build new types of social connections in a future Europe. So, it's a very complex long-term problem that will require a lot of collaboration to get through it.
Thank you. No, that's super helpful. So now we can turn over to ALYCIA, coming back to some of the kind of the detail. I think folks who may be in the healthcare industry or interested in how this is working, if you wouldn't mind commenting on just some of the specifics. I think, you know, there's 25-ton ship that's leaving tonight.
Yeah, I'm sorry, I couldn't hear for a minute there, but I can just at least go over what we're hearing about some of the needs on the ground and just kind of our main concerns at this point in time, which, you know, they're certainly changing really rapidly. So just starting with, you know, how we're thinking about it, it's really two different categories. And the first one is really this acute phase that Thomas mentioned. So medications and supplies to address kind of the mass trauma from the high number of casualties. And so the types of products that we're hearing are most needed right now are things around wound care, bandages, tourniquets, things to manage severe bleeding, burns, shock, things for anesthesia, IV antibiotics, and specifically oxygen, which is something that, you know, unfortunately we're familiar with for our COVID response. And so those are the types of items that really are the most urgent at this point since day one. And we were also working pretty closely with the Society of Critical Care Medicine, and they have about 850 members on the ground. And they have also expressed the same kind of urgent specific needs for the trauma care. And so the first shipment that went out was, you know, the backpacks that had a lot of the wound care items in there and the tourniquets. And those were the first things that were requested that have already luckily been able to make it there. And then moving on to more chronic disease needs and their health needs in the refugee population. You know, this is something that we knew the chronic needs were there and there are gaps that existed before this all started. And so the cardiovascular rate of disease, like Andrew mentioned, is high at baseline. I think today on our call with the WHO, they were estimating about 450,000 insulin dependent diabetics in Ukraine. And in conversations with some of the intensivists, we also know, and surgeons, we also know that, you know, all of the kind of primary services have been stopped, all of the oncology services, the elective surgeries, and it's really just to make room for all of these mass traumas. But from our work and our history, we understand, as Thomas mentioned, that these things quickly turn into emergencies if they're not controlled. So things like going without asthma medications turn into an asthma attack, and not having insulin turns into diabetic ketoacidosis, which is life-threatening. Lack of cardiovascular medications lead to increased risk of stroke and heart attack. So we understand that these downstream effects are coming. There's also a whole risk associated with delayed care. And so, you know, understanding that that is coming and that's going to be covering a large population. So the shipments that are going out, one I think just left our warehouse and the other one was picked up last week, are really meant to address both these acute phase as well as the chronic needs, the more longer term issues that, you know, we want to make sure that are managed properly. And then just another kind of third thing to think about is every time there are these large evacuation events, there are always these unique circumstances that tend to complicate the issue. And so we've seen this pretty much across the board. A lot of times it's around communicable disease. Just, you know, one example is the California wildfires that we had here. We saw a huge norovirus outbreak in the shelters. Severe need for polio vaccines with Afghan refugees. And here in this particular instance, the main concerns are COVID, which, you know, at this point in time, it's really been deprioritized, understandably. That's why we have triage. And so, but the crowded conditions and the low vaccination rates within Ukraine and surrounding countries is worrisome. There's also been discussions about drug-resistant tuberculosis and HIV, and that has been mentioned in some of the cluster calls that we've been part of. And then you have, you know, the population of a lot of children maternal health issues, as well as, freezing temperatures. And so this is really like a multifactorial way of looking at the response, acute, chronic, and the unique circumstances that this brings. And so we're trying to coordinate the needs lists across the different groups, match them to inventory, make sure that we're maintaining our conversations with the Ministry of Health, with our existing partners on the ground, and also really bringing in these international health experts and organizations that really specialize in these areas of care. In some places, we still have, some missing information, and we're having to make assumptions, as Thomas mentioned, with kind of epidemiological factors, the percentage of diabetes within country and surrounding countries, the percentage of hypertension, causes of death, and trying to estimate what the projected needs might be over a 1 month, 3 month, 6 month period. So when you take into account, what's happening within Ukraine and also in surrounding countries, it's just a lot of need. So we have a staff member on the ground now in Poland who's also doing some additional assessment with the refugee population. So we're just trying to get the information as it's coming in, and trying to just manage all of the flow of all the different sources of information and match it to our inventory and what we're able to provide. And we're really fortunate to have the support of those on the call, and really thankful for that. So it's a really brief overview, but it's easy to get kind of carried away in all the details of the specific medications and products. But I just wanted to give at least an oversight of what we're looking at.
Yeah, thanks, Lisa. I think a couple of things that, the Society of Critical Care Medicine, that they're the International Society of people who, the intensivists, or who staff ICUs, the intensive care units. So we've worked closely with them throughout COVID, helping us identify kind of the broad issue of oxygen, how to lean into that. We kind of have a pool of money that just focused on that because COVID exposed the chronic shortage and lack of surge capacity with medical O2 broadly. So I think, that's one of the things that lends itself to focus. But the fact that they have 850 members who are managing intensive care units in Ukraine and the bordering countries, that's kind of a narrow but precise source of information. So that's kind of coming into the mix a little bit. And also, I think we work closely with the International Confederation of Midwives. So I think, again, who's vulnerable in emergencies, like really young people and really old people and people with disabilities. And so I think they're European-based, they're plugged into the midwifery networks. So it's something that generally it's not necessarily front of mind for a lot of folks, but it's something that we often see and often end up doing with whatever financial or material support is needed, just to make sure that deliveries are, done. It's Europe, so it's much different than in a lot of other places where we've had big active responses. But those kinds of factors, I think, provide us, and it's good information, so you can key off of it and lean into it, particularly with the intensivists, who, one of the reports was that they've had to remove COVID patients in ICUs to make room for the trauma patients. So it's like the cascading effect, obviously, triage. But what we have seen, and who would anticipate, every time something where there's a big spike in urgent care needed, everyone around the world, including in the US, always concludes the primary care needs to get more mobile and get out there. It doesn't have to be facility based. So we end up directly purchasing and providing a lot of vehicles for either patient transport in or medical services out at a primary care level. And that tends to be a recurring pattern. Some of it has been leapfrogged by telehealth, but not all of it. I mean, that's something that's very common, and one could anticipate, at least within Ukraine. I think some of the other specific questions or some information that we learned, that the 34 hospitals have been damaged or destroyed. This is kind of the, today there's daily calls for at the World Health Organization or UN for the different clusters. So directly sits in the health cluster and the logistics cluster. So that's sort of where the information is kind of brought together and shared. But 34 hospitals damaged or destroyed in Ukraine, 300 healthcare facilities no longer in control of Ukraine. So I think, again, increasing need, decreased capacity, some of it intentionally inflicted, and kind of chronic becoming acute, injuries becoming, obviously needing to be attention, and these millions of folks on the move. So let's see if there's any other questions. I wanted to characterize fairly, I think, just some of the ability to respond to the near term. Direct relief has been extensive. I think I think WHO is looking for, they have to do a funding pool, and then they have to do a procurement. It can take a few months. So we're fortunate, we believe at this point, to have existing warehousing accredited storage facility in the Netherlands. It's a 14-hour drive to the border. We were talking with WHO, the NCD team today, about their at least near-term plan to set up a medical distribution hub with cold chain in Poland. We're looking at that ourselves too, because we have current inventory that we can move closer to Ukraine. And also then our resident staff member who's in Poland today, she's a resident of Macedonia. So I think with Romania, Moldova, Hungary, some of the areas that are likely to receive, we want to make sure that we understand where the center of gravity is within the country for refugees, and then work productively with those host governments, many of whom may need or seek some philanthropic support, which is what we are set up to do, really with the partnership of many of the healthcare companies that we work with on a routine basis. So I think the shipment, someone had asked, that's leaving today, it's a 25-ton, 67 pallet delivery. And also somewhat more sensibly, so I can't get into the particular detail, but there have been medical inventories made available to Direct Relief in Kyiv that were already in the country. Some of the donor companies were gracious enough to make them available. So we have been kind of trying to manage those inventories virtually, make sure that the match is made, and then the local logistics are handled to kind of, it's really the quickest hit. And these are some substantial inventories of everything from respiratory medications to cancer therapies that people need to maintain because they're in active treatment. So I think that's great, from our perspective, be able to, in the chaos, take advantage of the locally available resources and connect them as we would normally do, often, shipping stuff from a distance. So yeah, that's kind of where we are now, expecting it to change daily. I think our plans include mobilizing the medical material to complement and insert what's needed, that's not going to interfere with markets, what markets do naturally and what governments often do. And there's always a gap someplace. So I think that's the role we understand that role. Narrow but deep on things like support for cold chain medications, insulin for people who need it, just because Direct Relief has a lot of experience doing that and capability already in Europe, that, it's not that far away. And there's substantial resources in Europe. So I think it's not an environment where it's a weak, fragile infrastructure in a developing country, which just adds to the complexity and challenge. The good news in this horror is that the ability to mobilize resources, both public and private, it's Europe. I mean, the infrastructure is fantastic. There's kind of EU commonality for things like registration and compliance. That's always an issue for any organization that handles prescription medications, and kind of this great good faith of people coming together. So we're, our role is, rather narrow, but pretty deep, and just very thankful to be in a position to be helpful. And also in a position, as we've seen throughout COVID, to provide financial support, because there's a lot of international controls on the movement of anything, right, of value, whether it's money or medical material. So I think what we've seen is that in India, for example, where we do a lot of work, we understand how to comply. Every shipment Direct Relief sends is technically under US tax law and control law, it's a grant. So we have to approve every of the 30,000 shipments as a year through the Office of Foreign Assets Control, anti-money laundering, Foreign Corrupt Practices Act routinely and all the Patriot Act rules. So I think the ability to support Ukrainian groups that are properly registered end up with a lot of responsibility. They don't have access to philanthropic resources that may be coming available to a group like Direct Relief. So that's part of our approach as a support organization, do whatever we can to really leverage the capabilities to connect to available private philanthropic medical material resources, but also do similarly with private financial resources that are entrusted to us to make sure those get in a clean, precise way to people who are going to use them well. So we've already been able to kind of start that in a modest way with an initial financial grant of $100,000 to the local Ukrainian group that was able to get through, and they, the wire transfer went successfully, picked up, so they needed that operating cash. So that's something we'll be looking to do to the extent resources permit in the days ahead as well.
One just thing to kind of emphasize, kind of along the theme of things that are true here, which we often see in other responses, is that even though actually we, Europe, we think of as being a place with very strong state level systems and have, government programs that deal with a lot of this, a lot of the refugee response is actually driven by civil society, NGO level groups within Europe that are of a pretty broad spectrum and a lot of varying capability that are just as in over their heads on a lot of this scale of activity as everyone else. And so I think one of the things that Direct Relief has routinely done well over the years is to identify who those groups are, in the countries that are affected, that are local, not maybe on the ordinary map of where kind of the international, kind of the highly named international response is, and make sure that there are resources at that level, at the level of, Polish NGOs, Romanian NGOs, and others that are, going to be providing a lot of that care. And I think that's something to keep a real eye on going forward, is the localization of this response. That's who's going to be there for the long term. That's where a lot of the resources need to flow. And these are the groups that are going to be connected socially to the refugees as they kind of sort out what this means over the longer term. And I do think that's one of the most strong, flexible kind of, approaches, both within health and in kind of health extended into kind of broader community needs as well.
I think one of the questions we have time for maybe one or two is that, what is working or is unusually difficult? Are there unusual needs you need help answering? And I mean, I guess my take on it, Bill, would be that, it's still early. I mean, we've gone from kind of this fully functioning, 2 weeks ago, to kind of normal, to this extreme reversion to wartime conditions unseen and probably in Europe, certainly probably anyone's lifetime on this call. And it's kind of harkens back to the things you read about. And Direct Relief's founder was, the reason Direct Relief exists because there was the guy who founded it, it was originally a private foundation. He was Estonian, and he was a high net worth Estonian who Hitler tried to recruit, and he famously rebuffed him and called him a fool and had to flee. He got on the kill list and ended up in, of all places, Santa Barbara, California. So when he passed away, what's now Direct Relief was a greatly diminished residual of his estate. Then it became a public charity with living off the land, paying as we go for 50 or 60 years. But that was its roots, both in Europe and sort of aversion to affiliating, being involved in politics, being a secular organization, working with all religions, but no religious kind of particular flavor or character. And the business roots, recognition that you have to invite the participation of the private sector who do things well. They just happen to do it for business reasons, but many of those, they're not in business long if they don't perform those functions well. So many of those same functions, logistics, information flow, decision-making, optimization, are exactly what's needed, even more so for humanitarian purposes, because there's fewer resources and the stakes are quite high. So I think that was all baked in the roots of the organization. So it's kind of profoundly sad and just weird that Direct Relief is back kind of where these activities are unfolding is in the same neighborhood of why the organization exists in the first place. But privileged to be able to lean into it and help. The other one, I think, I'm not sure we have a good answer for, but I think it's because of the mention of biometric identification and some reports of trans people in Ukraine whose ID gender on there doesn't match their gender. And so the ability to kind of cross borders is compromised. And I haven't heard this emerge, but I understand, and thank you for asking that question. But Andrew, is there anything, because you're in different kind of circles who are looking at the human rights involved in this, and this is clearly one that one of the attendees is aware of.
I think it's a really important question. I will be really honest, I don't know the answer to the question. And I think we can follow it up around, the rights of people that are, that are fleeing from war and are seeking resettlement and access to services. I mean, it's sort of above our kind of level of intervention, by the way, and in the sense that that's really a policy question in Europe, but I think it's an important one to follow up for sure. And I'm sorry, I don't know the answer to that.
Yeah. Well, and then finally, I think there's a, thank you, Rakesh, there's a report of Lithuania stopping a shipment of COVID vaccines to Bangladesh due to the latter not voting to sanction Russia at the UN. So the observation is this creates an intersection of global vaccine inequity and the Ukraine crisis. What is Direct Relief doing to ensure that the COVID vaccine campaign continues on track even as these kinds of intersections occur? I guess, Rakesh, my take on it is that, although we have been involved rather narrowly, I mean, the vaccine has been managed almost exclusively by governments, including the US as a big buyer. We've been involved in bilateral vaccine, COVID vaccine support to Mexico, just because we have Direct Relief Mexico. And we're familiar with handling. We have ultra temperature, -2 to 8 and -20. So we're well set up to do that. But internationally, the COVID vaccination has been government to government. We are not really involved, but our view is that as a lot of unused vaccine is in the US. I mean, it's a take issue. But certainly our view would be that those types of issues would never impede Direct Relief actions. I think if the Lithuanian government objected to something that they were in a position to provide, that's kind of a political question that we may have a view on, but withhold comment because we're not involved. I think our view is that everybody should have equitable access, and we will do as much as we can to open those doors and make sure that happens. That's kind of our mission as in a political humanitarian organization, as much as we possibly can. So we ran late. Sorry if that was too much rambling, but I can't thank you, the 64 of you who remain on the call, for just being interested, asking great questions, and those of you who've been part of the support effort. Many thanks. It's never expected. It's always deeply, deeply appreciated, and we will keep on it as much and as hard and as long as we possibly can. So thanks a lot, everybody. Stay safe.